Welcome. My name is Corey Richardson. I'm the CEO and Clinical Director of Integrated Care of Greater Hickory. This corporation provides community behavioral health services in Western North Carolina predominantly, and we offer counseling, medical services, pharmacy and toxicology services, transitional housing, transportation, and prevention for our populations. And so this is a talk about the history of PA impairment, treatment monitoring, and research in the field. I have no conflicts of interest other than the ones that I just listed, it being CEO and clinical director of a community behavioral health corporation. I will, however, mention I am a former PA, graduated from the University of Florida's College of Medicine, and I am also a person in long-term recovery. So an overview. We will discuss the purpose of my research with PAs with substance use disorders, and we'll call them SUDs during the rest of the talk. And we'll review the presentation in total, what it's for. We're going to go into the background of PAs with SUDs, the rationale for the research study, and the significance of the study, followed by the methods, results, discussion, and a conclusion that tie to the research that I did with North Carolina PAs. So an overview. We will discuss the purpose of my research with PAs with substance use disorders, and we'll call them SUDs during the rest of the talk. And we'll review the presentation in total, what it's for. We're going to go into the background of PAs with SUDs, the rationale for the research study, and the significance of the study, followed by the methods, results, discussion, and a conclusion that tie to the research that I did with North Carolina PAs. So why are you here today? All healthcare providers should have a general knowledge about drug and alcohol use disorders within various healthcare professions, and therefore we should be able to advocate for future research to secure quality treatment and monitoring for healthcare providers. The purpose of my research, and I'll review this one more time before we get into the study, was this is a quantitative descriptive study to measure treatment readiness in North Carolina PAs that were currently or previously enrolled in the state's monitoring program for healthcare providers with SUDs. So let's get into the history. SUDs and healthcare providers create a serious risk to patients and the public at large, and have a direct negative effect on the quality of care delivered. One review demonstrated about 10 to 15% of all healthcare providers met criteria for SUDs, and this rates for nurses range from about 14 to 20%, and physicians around 10 to 12. And while there might be some various rates within a lot of different studies, this generally is accepted as healthcare providers have about the same rate as the general population. I did a meta-analysis in 2015 for the Journal of American Academy of PAs, and in that meta-analysis that was published in JAPA, I did determine that the extant research concerning SUDs within the profession was extremely limited. However, the PA profession continues to grow at a rapid pace. And so such research in this field is greatly needed for the public good, as well as the health and well-being of PAs themselves. So healthcare professionals have not only demonstrated higher rates of certain use of certain drugs, such as benzodiazepines and opiates, as compared to the general population, but have higher rates of use have been associated within specific specialties. Furthermore, professionals in various fields use substances for different reasons throughout their careers and have had varying success rates in treatment. PA impairment, as defined by the American Academy of PAs, is any physical, mental, or behavioral condition that interferes with the ability to safely engage in professional activities. And so substance use disorders fall into this category. And the AAPA reported to me that the Academy has never collected data related to PAs with substance use disorders. I think that's a little bit disarming because the AAPA collects a lot of data on PAs, education, practice, income, but such a serious condition within the profession and how it can affect performance of PAs and the delivery of the quality of care that's delivered, I think it's very concerning, and I think we need to address this within the profession. So the history of quote unquote impaired healthcare providers. So during the 70s, in response to a significant public safety concern surrounding physicians with SUDs, nearly all medical associations instituted regulatory interventions to create state monitoring programs, usually in the form of physician health programs, which we call PHEPs. And in 1981, the Michigan Academy of PAs created the first committee to address serious issues of PA impairment in that state. Similar committees exist in all states today, and they're usually composed of PAs themselves and have various goals related to assisting impaired PAs, addressing PA wellness, and protecting the public health. So these committees and their work with voluntary participants preceded the state legislation for mandatory monitoring of licensed impaired PAs. So monitoring PAs in the 1980s and early 90s, the inclusion of PAs with SUDs alongside physicians and other providers in state PHEPs began. And today, state PA academies generally have entered into agreements with PHEPs or similar monitoring programs for licensed professionals, although PAs are often by law permitted to self-monitor like nurses. They generally will fall into the physician health programs. Individual states have promulgated laws and regulations with varying degrees of PA peer review to oversee monitoring of treatment for licensed PAs. And Charlie Kober points out that PA review is an essential aspect of addressing impairment within the PA profession. So the research on PAs have included research data alongside other healthcare professionals, where some researchers have grouped PAs apart from physicians with a group that's called non-physicians, like dentists and pharmacists, while other researchers have studied PAs along with MDs as a unified group. So consequently, assumptions related to PAs with SUDs have largely been derived from studies of other healthcare professions. And the PA profession is definitely not equivalent to other professions legally, financially, or with respect to education and training, or in the form of practice. And if differences of incidence of SUDs and treatment outcomes are associated with differences between the various healthcare professions, or even between specialties, then future research should address this gap in the body of knowledge concerning SUDs specifically within the PA profession. So there is a growth in the PA profession that's continually expanding. And so the National Commission of Certification of PAs certified in 2018 alone 9,287 PAs. And that's the highest number since the NCCPA began issuing certifications in 1975. And so at the end of 2018, we had over 131,000 certified PAs. The U.S. Bureau of Labor Statistics projects a 31% growth in the PA profession from 2018 to 2028. And that's a much faster than average as compared to other occupations. So why is this significant? With a rapidly growing number of PAs in the country, with assumed rates of SUDs around 20 to 15%, this would lead us to assume that there was at least around 13,000 to around 19,000 PAs that would meet criteria for SUDs in the United States. So let me just give you an example. Around the time of my study, there were around 5,238 licensed PAs in North Carolina. And even if you just looked at the lower number, that 10%, you should have at least 524 that would meet criteria for a substance use disorder. At the time I did my research, about 0.5% were in monitoring. And so in 1985, the North Carolina Academy of PAs formed its health committee to address PA impairment through education and support. And this followed some legislation in 1993 allowing for intervention, treatment, and monitoring of licensed PAs with SUDs. The NCAPA, that's the North Carolina Academy of PAs, contracted with the North Carolina Physician Health Program to monitor PAs with a substance use disorder, in part because of the extremely high success rate that the physician participants in the program were showing. And across the country, various healthcare professionals had also been using the same monitoring for PAs. So the North Carolina PHEP uses a model of treatment and monitoring that's recommended by the AMA and shown to be effective. Still, when studied by Ganley et al., the success rate did not translate into good results for the PAs monitored in North Carolina. So let's look at the Ganley study. It was a retrospective chart review. And then prior to my research, it was really the only research that was related specifically to licensed PAs with substance use disorders. And it was a 6-year retrospective chart review in North Carolina with those monitored PAs. The Ganley study found that although 91% of the monitored physicians with addiction in the program had very good outcomes, only 59% of the monitored PAs did. So it's a huge disparity there. The good outcomes were defined as without complications, and these were completed contracts through the program or completed contracts with another state. Good outcomes with complications were defined as completed contracts with incidents of recurrent use, and poor outcomes were defined as contracts that weren't completed for any reason. The contracts lasted either 3 or 5 years, depending on the severity of the disease determined by assessment. And for an as yet unidentified reason, physicians had much higher success rates than the PAs. So this is a slide from that study, and you can see that there were 233 physicians as compared to only 34 PAs that were reviewed. So Dr. Ganley conceded with an email correspondence with me, and I know Dr. Ganley through our work on the PA Health Committee in North Carolina, where I'm a consultant, or was at that time. There was a very small sample of participants that may have produced some inconclusive results. He stated that they did not measure the severity of the substance use disorder prior to detection, although you can assume that because of the 3 and 5 year contracts, that some assessment placed them into the appropriate contract. He did not identify any related comorbidities in that chart review. And interestingly enough, I found the most interesting, they did not measure the difference in the level of care received for treatment prior to monitoring. So physicians might have gone to an inpatient facility like Talbot for 90 days or more, and maybe due to financial reasons or others, PAs may have gone to outpatient treatment or straight into monitoring without any treatment whatsoever. And so that was not determined in the chart review. Some other neglected key indicators of relapse or recurrent use, which we know is important: regular or meaningful 12-step participation, appropriate use of AA or NA sponsors or professional mentors, identifying spiritual development, exercise, and leisure activities. So there was a lot of things that could have been used to maybe give a better framework for the retrospective chart review, but just was not available. But maybe it was just the North Carolina PAs. Maybe it wasn't. Maybe it's not all PAs. I did look at the Colorado Physician Health Program, which publishes some very favorable results on its website of the 126 PAs that were in state monitoring from 92 to 2013. And 97% of these had treatment success. This was on their website, and it was also confirmed in personal communications. Yet, of these successful outcomes of monitored Colorado PAs, only 27% of PAs monitored were listed as a substance use disorder, and with only 9% listed as driving under the influence or driving while ability impaired. And so that's a smaller percent of PAs with a SUDs disorder, a substance use disorder in Colorado than in North Carolina. And when I reached out to Daniel Mattingly, who's the advisor to the PHEP, North Carolina PHEP at that time, He reported that 24 of the 29 active cases, about 83%, did have a substance use related impairment. And that's why the case was opened up, and that's why they were in monitoring. So huge disparity there of the type of program between Colorado and North Carolina. And so since the two state programs had such different populations, it's really very difficult to compare those results. But what about nurses in North Carolina? Um, so one of the managers I reached out to reported that about 145,000 nurses are licensed in North Carolina at the time of my research, and yet only monitoring occurred for about 250 participants. So again, if you took statistically the lower level of the incidence of substance use disorders within the nursing population, we'll place that at 10%, which is a little bit lower than some of the research studies have demonstrated. You should have at least 14,500. With that number, the current number that are being monitored in the program would be about 0.17%. Another consideration for our North Carolina nurses, since the number was so small, one might consider that most nurses with a substance use disorder in North Carolina would avoid detection except for those with very advanced disease, 0.17%, as opposed to what we would statistically think we should have as around 12 to 14%. So one might expect these nurses with very severe disease would have very poor outcomes, depending upon the specifics of monitoring, contract, and its enforcement. Still, North Carolina Board of Nursing reports very high success rates, and this was confirmed by personal communication as well. So prior to my study, there was the Ganley study, which was the retrospective chart review for licensed PAs and monitoring. And only one other study really selected out PAs, but these were PA students, and they were looking at rates of SUDs within a student population, not in licensed providers. So the rationale for the study is pretty clear at this point. Determining what, if any, differences exist for PAs may be helpful in detection, assessment, treatment planning, and monitoring, and possibly leading to improved treatment outcomes for PAs with SUDs and leading to improved patient care by PAs with SUDs who were returning to practice. And it was clear that the current body of knowledge was inadequate and is still inadequate to address these questions. Research is needed specifically on PAs with SUDs to improve the current body of knowledge. I want to review one more time the purpose of my study. It was a quantitative, descriptive research study, a primary research study, to measure treatment readiness in North Carolina PAs that were currently or previously enrolled in the state's monitoring program for healthcare providers with SUDs. There were two research questions that were tied closely together, and that's what is the treatment readiness of North Carolina PAs that were currently enrolled or previously enrolled in monitoring by the state for healthcare providers with SUDs. The study participants, North Carolina Physician Health Program, reported that 71 past and 19 current PA participants were in monitoring for SUDs. There were 20 participants that completed the online questionnaire for this study. The recruitment process was carried out by the North Carolina Monitoring Program's directors through an invitation email that outlined the purpose of the study and also ensured the anonymity of participants and reassured participants that the study had no effect whatsoever on the participation within monitoring. Data was collected between September and October of 2016. The inclusion criteria were PA participants currently or previously monitored since the inclusion of PAs in October of 1994, and the exclusion were any PAs that were previously or currently monitored but were for issues other than SUDs. The study was reviewed by the Institutional Review Board and approved. And survey development, I was very blessed to be able to work with Dr. Melnick, who created the survey tool back in the 80s. The Circumstances, Motivation, and Readiness Survey instrument was adapted with Dr. Melnick's approval for PAs. We did remove the suitability scales, and that was a subscale that's specific for residential treatment. The CMR survey instrument still has been demonstrated to have high validity and high reliability to the original survey tool. Treatment readiness is operationally defined within 3 subscales, which include circumstances, motivation, and readiness. Circumstances were defined as external conditions to enter or leave treatment. Motivation was defined as a person's inner reasons to enter treatment. And readiness was defined as a perceived need for treatment. A higher total score indicates a higher level of treatment readiness, which is a predictor of retention in treatment and improved treatment outcomes. Like I just described, validity of the CMR and the reliability were both measured, and they relate very highly to the original CMRS survey tool. Scoring were calculated, and there's a scoring tool that was used that we adhere to pretty closely. And you can see the breakdown of the subscales to the items on the survey tool. And here are some more guidelines that were used for our scoring guide. Data collection. So the invitation was sent via email to 90 eligible PA participants on September 7th of 2016 via the research assistant within the monitoring program. And they sent out an email explanation as well as a link to the online tool. 75 emails were presumably received successfully by PAs who were eligible to participate, which means they didn't ping back as non-deliverable. The survey tool took approximately 10 minutes to complete, and 2 months were permitted to allow prospective participants to complete the survey tool with 2 reminder emails that were sent on September the 21st and then again on October the 5th. Data collection, no data collection obstacles were occurred whatsoever, and I had no access to any identifying participant data. I used the IBM SPSS version 24.0. Descriptive statistics were used to analyze the scores. Some of the demographic variables included sex, ethnicity, primary drug use, treatment modality, current licensure status, specialty, active versus inactive program enrollment, status, and completion status. Participant age, years of practice, length of time in program, and last year of participation were also collected. And respondents were provided several options, but other and please describe for certain demographic items that allow for more concise information collection or data collection. We did not offer the answer prefer not to answer. So frequencies and valid percents were calculated, and normality testing was conducted, and appropriate measures of central tendency and dispersion were reported. So to determine treatment readiness of North Carolina PAs with SUDs, either currently enrolled or active in the state's program, the individual score values of each scale were summed to derive the subscale values, and the higher the total score would represent a higher level of treatment readiness. The same statistical analysis that occurred for those that were currently enrolled were also performed for the previously or the inactive participants, so that we could compare the results of those who were no longer enrolled in the program with those that were current. So this is a table representing some of those demographics. So here are some of the results that describe the sample. So there were 27 North Carolina PAs that did respond, and 26 of those met criteria for inclusion. Of those, 20 respondents completed the survey questions, and that's a completion rate of about 76.92%. The demographic values that I just described were listed. The sex of respondents was evenly distributed between male and female. All were Caucasian. 16 of those 20 respondents had licenses to practice medicine. 2 respondents had restrictions on their ability to practice. Of the 20 respondents, 7 were actively monitored, 8 had completed the program, and 5 had withdrawn, transferred to another program, or had been terminated. Alcohol was identified as the most common substance for 11 of the 20 respondents. Normality testing was conducted with the mean age of respondents of about 49.05 years, mean years of clinical practice 17.5, and the mean years since exit from monitoring about 4.83. All were normally distributed. Participant months in enrollment in monitoring, however, ranged widely without any normal distribution pattern, and they range from 3 months to 132 months, with a median of 54 months. And here you can see the breakdown of the subscales and total scores. Research question 1, which for those were currently enrolled, it was demonstrated that active participants had approximately 75% of the maximum scores possible, and this does represent higher levels of treatment readiness and predicts higher rates of retention and improved treatment outcomes. Research question 2 were the previously enrolled participants, and again 75% of the maximum score possible, which represents higher levels of treatment readiness and predicts higher rates of retention with improved treatment outcomes. So with respect to our 2 research questions, the CMR total scores for both currently enrolled or previously enrolled indicated similar levels of treatment readiness, and both groups had these elevated treatment scores. While various healthcare professionals had demonstrated higher rates of SUDs with certain drugs and varying rates of SUDs within certain specialties, almost no research has been performed on PAs suffering from SUDs. With the ever-growing number of PAs practicing in the United States, this poorly understood phenomenon may represent a true risk to public safety. Most licensed PAs with SUDs are currently monitored within physician health programs, which makes PHEPS an ideal setting for studying this population. Previously, there had been only one research study to isolate PA outcomes in a monitoring program. This retrospective chart review found poorer SUD treatment outcomes for PAs than for the physician counterparts. The lead investigator conceded the small sample size may have contributed to those inconclusive results. Juxtaposed to Ganley's findings where PAs had poor treatment outcomes, this current research study suggests PAs both active and inactive in the very same monitoring program should have improved treatment outcomes due to elevated CMR scores, as elevated scores do indicate higher levels of treatment readiness, predict longer rates of retention, and improved outcomes. Both the small sample size and the lack of diversity do greatly limit generalizability of this current study to the population of PAs diagnosed with and monitored for substance use disorders. These findings suggest that North Carolina PAs, whether active or inactive in monitoring, have elevated levels of treatment readiness that do predict longer rates of retention over those with low scores. While this current study is only a pilot study with a very small sample size, these initial findings challenge the general implication of Ganley's findings that PAs do poorly in monitoring. There are certain limitations within my research. The inclusion and exclusion criteria allowed for the greatest number of respondents. The survey participation information clearly outlined how confidentiality would be protected and that survey participation would not affect monitoring. While all email invitations were presumed to be successfully delivered to current and past participants, the low number of respondents resulted in a small sample size. The small sample size may be due in part to the highly sensitive nature of licensed healthcare professionals with this disease. Of the questionnaires completed, all were from white respondents. Both the small sample size and the lack of diversity greatly limit the generalizability of this study to the population of PAs diagnosed with and monitored for substance use disorders. The data collection instrument employed may also have limited this pilot study. The survey instrument is worded for participants initially entering treatment. It is not worded for participants having completed treatment, for those who have never had formal treatment, and not for those in monitoring. So some respondents may have been confused by this, even with the introductory email that asked the respondent to place him or herself in the mindset of their initial treatment experience. Another question posed by respondents related to the fact that some had gone directly into monitoring after detection and diagnosis without any form of formal treatment. This option could be added to the treatment modality. Adding benzodiazepines specifically as a primary drug would also be considered, as respondents had to write in this response. Keep in mind this is an old survey tool, and certain drugs like PCP and barbiturates were much more common when the tool was initially created, and benzodiazepines were less of an issue at that time. Recommendations for future research. A closer examination of the demographic data is needed to explore possible relationships between treatment readiness scores and treatment modality, the age of respondent, primary substance use, and treatment outcomes. The CMR survey tool may be further modified to improve its fit to the PA population with SUDs in a monitoring program, such as to include monitoring only and community 12-step participation as treatment modalities alongside the other formal treatment modalities. Future research might facilitate the creation of guidelines to match the appropriate treatment modality to respondent CMR scores. Furthermore, future research using larger sample sizes is needed to increase its external validity of the study. Larger sample sizes would also improve the chances of detecting relationships due to differences in demographic characteristics and better describe the target population. This may be accomplished by contacting the Federation of State PHEPs and asking its president to invite other PHEPs to issue the same survey. An IDAA may also be instrumental in the recruitment for future studies. Another consideration for future study is to pursue comparisons of PAs to other healthcare professionals and state PHEPs, such as physicians, using the same modified CMR survey tool, or may include participant treatment readiness scores associated with the treatment outcomes. In conclusion, the purpose of this quantitative descriptive study was to examine treatment readiness of North Carolina PAs with substance use disorders currently or previously enrolled in the state's monitoring program. The CMR total scores for the sample of North Carolina PAs, whether active or inactive in monitoring, were elevated. These scores are indicative of elevated treatment readiness, which predict higher levels of retention and better treatment outcomes. While this current study was only a pilot with a very small sample size, these initial findings do challenge the implications of the Ganley findings, which suggest PAs in monitoring may be less suitable for treatment and expected to have worse treatment outcomes. This current study finds PAs in the very same North Carolina monitoring program as the Ganley study to have scores indicative of higher levels of retention, which statistically result in better treatment outcomes. Here are my references, and this relates to the research as well as the meta-analysis that was performed in 2015. Here's my contact information. If you wish to review the raw data or contact me about the study findings, or more importantly, if you're interested in participating with future research related to PAs and treatment monitoring, I look forward to talking with you. Thank you for watching our webinar today, and look forward to working with you in the future.